So imagine this. A 19-year-old takes a really hard fall on the ice, and he's complaining his back hurts.
Oh, classic.
Right. And then just a few rooms down, a 25-year-old takes an elbow to the head in a volleyball game. She seems maybe a bit dazed for a second, but now she's just sitting up, laughing, chatting with her friends.
Yeah, totally normal scene in any clinic.
Exactly. But in the world of primary care, the most terrifying, life-altering emergencies, they often walk through the clinic doors wearing the exact same masks as, well, everyday bumps, bruises, and headaches.
It really is the absolute definition of diagnostic muddy waters.
Hmm.
I mean, when you are in the clinic, you just don't have the luxury of a neat little label that says neurosurgery or infectious disease hovering over the patient's head.
Right. You are the very first line of defense. And today, our mission is tailored specifically for you. Whether you are, a dedicated medical student cramming for the USMLE Steps 2 and 3, or maybe a young professional trying to find your footing in a really busy family medicine clerkship.
Or just an insanely curious lifelong learner.
Yeah, exactly. Just aiming to sharpen how you solve complex problems. We are finding out how to spot the difference between a common ache and, quite frankly, a ticking time bomb.
And our roadmap for this deep dive is a really fantastic piece of source material. It's the third edition of NMS Q&A Family Medicine, authored by Dr. David R. Rudy.
Oh, a total classic.
It really is. I mean, this text is practically a rite of passage for med students. It covers just a staggering amount of ground, from urgent triage all the way to geriatrics.
Which is overwhelming, honestly.
Oh, completely.
Yeah.
So my goal today is to take this massive 15-chapter table of contents and sort of distill it into actionable, underlying scientific principles. We want you to understand the actual why behind the diagnosis so you can apply it when a real patient is sitting right in front of you.
Well, let's jump right into the deep end with the single most common complaint you will ever hear in a clinic, which is low back pain.
Oh, yeah. Everybody's back hurts.
Right. So the book describes this 60-year-old man. He has type 2 diabetes, and he comes in with unremitting lower back pain. Now, my immediate thought is, okay, who hasn't had a sore back?
Right. He's 60. It happens.
Exactly. But then the text notes he has a low-grade fever. So as a doctor sitting in that clinic looking at this guy, why should that specific combination make my stomach drop?
Because that combination is a massive glowing red flag for a spinal epidural abscess. I mean, an SEA. The fever is the absolute giveaway that this isn't just a mechanical strain from, lifting heavy boxes.
Wow. Okay. So it's an infection.
Yeah, you are dealing with a rapidly expanding pocket of pus right in the epidural space, which is the area just outside the spinal cord. And you mentioned he's diabetic.
Yeah, type 2.
Right. So diabetics are in a state of chronic immune suppression. I mean, that puts them at a significantly higher risk for these sneaky, really deep tissue infections.
Okay, so what else am I looking for in the lab work to basically confirm I need to panic?
Well, if you pull a complete blood count, a CBC, you're going to see a highly elevated white blood cell count, maybe around 18,000. And crucially, you'll see what we call a shift toward immature forms.
Wait, immature forms? What does that mean for his immune system exactly?
Think of the bone marrow as a factory, right? A factory that produces white blood cells. When there is a massive, really severe bacterial infection, the body just hits the panic button.
Oh, so it just starts pumping them out.
Exactly. It starts releasing baby, undeveloped white blood cells, they're called band cells, straight into the bloodstream before they are fully mature. It just needs to get bodies to the front line of the infection.
Wow, so his body is just throwing everything it has at this abscess.
Yeah. And the most critical next step is absolutely not to prescribe muscle relaxers and wait. You must immediately order a CT scan of the lumbosacral spine.
Right that second.
Right that second. If you wait for neurological symptoms, like leg paralysis to appear, you've waited way too long. The spinal cord is already being crushed at that point.
Okay, now, let's contrast that infectious emergency with a mechanical one. This is that 19-year-old I mentioned at the top of the show.
Ice fall.
Yeah. He's morbidly obese, took a really hard fall on his tailbone on the ice. He's got pain, but when you check his reflexes, they are asymmetrical.
Okay, huge red flag.
Right. Normal on his left leg, but his right Achilles reflex is just gone. What is happening here?
This is cauda equina syndrome, CES. The impact of the fall has caused a massive herniation of a spinal disc, or maybe even bone fragments, to compress the bundle of nerve roots at the very base of the spinal cord.
The cauda equina.
Exactly, which translates to horse's tail. It's just a bundle of nerves dangling down.
So if I suspect this, checking for back tenderness obviously isn't going to cut it. What is the definitive physical exam I need to do right then and there?
Well, you have an absolute, totally non-negotiable need to check perineal sensation.
Meaning, like, the saddle area.
Exactly. The area of the body that would touch a saddle if you were riding a horse. You must test the inner thighs and the groin for touch and sharp and dull pain perception.
Oh, wow.
And honestly, you have to conduct a digital rectal exam to assess sphincter tone. I know it's not pleasant, but if they have saddle anesthesia, meaning they just can't feel that area at all, or if they've lost bowel or bladder control, you are officially on a very tight countdown.
How tight are we talking? Why is the exact timeline so incredibly critical here?
It really comes down to the hard science of nerve ischemia. That means blood starvation to the nerves.
That is absolutely terrifying. It's not just finding a needle in a haystack. It's basically finding a time bomb before it detonates.
That's primary care.
Seriously. And speaking of time bombs, if we move up the spinal cord to the rigid encasement of the skull, we get into neurological emergencies. Let's go back to that 25-year-old volleyball player who took an elbow to the head.
Right. This is the classic textbook presentation of an epidural hemorrhage.
Well, wait, she seemed totally fine. She was literally laughing and chatting after she got hit.
And that is what we call the lucid interval. And it is absolutely notorious.
Oh, so it's a false sense of security.
A deadly one. Underneath the surface, the blunt trauma actually fractured her temporal bone. That's the thinnest part of the skull.
Yeah.
And that fracture sliced right through the middle meningeal artery.
Okay, because it's an artery, not a vein, the blood pressure's much higher, right?
Exactly. High-pressure arterial blood is just rapidly pooling into the epidural space. That's the really tight area between the skull and the dura mater, which is, the tough outer membrane protecting the brain.
So what's happening during that lucid interval where she seems fine?
Well, during that window, her brain is basically just accommodating the slowly expanding pool of blood. It's squishing a bit, but the skull is a rigid box.
Right, it can't stretch.
It cannot expand at all. So minutes or maybe hours later, the hematoma becomes too large. The brain gets crushed under the pressure. The patient will rapidly deteriorate. They'll start vomiting, and they'll become obtunded.
Wait, obtunded. Let's clarify that term for everyone listening.
Oh, sure. It means she will become severely mentally dulled. Just unresponsive to anything except strong, painful stimuli. It's a massive neurosurgical emergency.
Wow. Now, contrast that blunt trauma with someone who just spontaneously gets the quote-unquote worst headache of their life. Just a thunderclap headache out of nowhere.
That is a subarachnoid hemorrhage. It's usually caused by a ruptured aneurysm. So, a ballooned blood vessel deep in the brain that just finally pops.
Okay, here's where it gets really interesting in the book, and honestly, a bit counterintuitive to me.
Okay, how so?
Well, if I'm the doctor and I suspect a brain bleed in either of these cases, the source material says to specifically order a CT scan without contrast.
Yep, non-contrast CT.
But instinctually, I'd think, hey, it's a blood vessel issue. Let's inject the contrast dye so we can see the vessels really clearly. Why is that a bad idea?
It's a great question that makes total logical sense. But think of it this way. Ordering a CT scan with contrast to find fresh bleeding in the brain is basically like trying to find a spilled glass of milk on a bright white tile floor.
Oh, because the blood and the dye look the same?
Precisely. Fresh acute blood is naturally very dense. So on a standard non-contrast CT scan, acute hemorrhage naturally shows up as a bright, glowing white signal against the darker gray of the brain tissue.
I see.
If you inject intravenous contrast dye, that dye also shows up as bright white. You would literally be pouring white paint over the exact white spot you're trying to locate.
Oh, wow, that would completely obscure it.
Totally. Plus, contrast takes extra time to prep and administer, and in these cases, brain cells are literally dying by the minute. You have to keep it simple, keep it fast.
Milk on a white tile floor. I will absolutely never forget that.
It's a good visual.
It really is. Now, sticking with the brain, the source brings up a totally different kind of neurological crisis. Wernicke's encephalopathy.
Oh, this is a fascinating one.
Yeah, so a middle-aged man is brought into the clinic. He's unkempt, severely disoriented, but his blood alcohol level actually isn't terribly high at the moment.
Right.
However, he has these involuntary eye movements, nystagmus and spider angiomas, those little web-like red blood vessels on his chest.
Yeah, this right here is a masterclass in nutritional neurology. The underlying cause here is actually not the immediate toxic effect of the alcohol itself.
Mm.
It is a severe chronic deficiency of thiamine, which is vitamin B1.
But why does lacking just one vitamin cause his eyes to twitch and his entire brain to basically shut down?
Well, because thiamine is a required coenzyme for the Krebs cycle. It's what allows your cells to turn glucose into usable energy.
Oh, so it's foundational.
Completely foundational. Alcoholics are notoriously malnourished, right? And alcohol actively stops the gut from absorbing whatever thiamine they do actually consume.
Double whammy.
Yeah. So without thiamine, the brain just cannot metabolize glucose at all.
Huh.
So despite all the empty calories in the alcohol, the brain cells are literally starving to death on a cellular level.
So that cellular starvation is what's causing the physical symptoms.
Yes, exactly. The classic triad is encephalopathy, which is the confusion ataxia, meaning he just can't walk straight, and oculomotor dysfunction.
The nystagmus.
Right. Specifically, the cranial nerves controlling the lateral rectus muscles in the eye, they just begin to fail, which causes that nystagmus and the double vision.
And the book is very specific about the treatment order here. It says you have to give intravenous thiamine before you give them any glucose. I'm guessing if you give glucose first, the brain still just can't process it, right?
Actually, it's way worse than that. If you pump glucose into a thiamine-depleted brain, you rapidly accelerate the cellular damage.
Oh, wait, really?
Yeah, it precipitates a permanent, irreversible memory disorder known as Korsakoff syndrome. You absolutely must prime the engine with thiamine before you add the fuel.
That is wild. Okay, so from nutritional deficits, let's look at how a localized ENT issue ears, nose, and throat turns critical.
Another scary transition.
Seriously, imagine a 17-year-old on a camping trip. He has bad allergies, gets a nasty right ethmoid sinus infection. He's out in the woods, doesn't have his antibiotics with him.
Typical teenager.
Right. Days later, he develops double vision, and the book says his right eye develops chemosis. What exactly am I looking at when I hear the word chemosis?
You are looking at a terrifying amount of swelling. Chemosis is when the conjunctiva, that clear membrane over the white part of the eye, it swells so much with fluid that it just balloons out.
Like a blister.
Exactly, almost looking like a giant fluid blister on the eyeball itself.
And how on earth did a sinus infection cause that?
This is cavernous sinus thrombosis. The ethmoid and sphenoid sinuses, they sit incredibly close to the cavernous sinus, which is a major hollow venous network sitting right at the base of the brain.
Okay, so they're neighbors.
Very close neighbors.
Right.
And the veins in the human face are valveless.
Meaning blood and, I guess, infection can just flow backward.
Exactly. The bacterial infection tracks backward from the face straight into the skull. The body tries to wall off the infection by forming a massive blood clot, a thrombosis, in the cavernous sinus.
Oh, wow. So the body's trying to help, but it backfires.
Huge backfire, because cranial nerves 3, 4, and 6 pass directly through that space. The swelling paralyzes the eye muscles, causing the double vision and that massive chemosis. It requires immediate, super aggressive intravenous antibiotics to stop it from infecting the brain itself.
Okay, let's just take a breath. We've survived the acute emergencies. Now we transition into what I think is the real art of primary care, connecting the dots.
Yeah, this is the fun part.
It really is. It's about recognizing physiological echoes, like how a finding in one completely different organ system acts as a homing beacon for the actual pathology.
This is exactly where a good primary care physician becomes a medical detective. Let's look at atypical pneumonia.
Okay.
A young adult comes in with a subacute, really hacking cough. Now, if you just listen to the lungs, you might shrug and guess maybe it's a viral bronchitis.
Sure, happens all the time.
Right. But then you use your otoscope to look in their ear, and you see a blister, a bleed right on their eardrum. It's called bullous myringitis.
Wait, so that one tiny finding in the ear completely changes the lung diagnosis?
Completely. That specific combination is the classic physiological echo for mycoplasma pneumonia.
Now wait, if I know it's a bacterial pneumonia, why wouldn't I just hit it with standard penicillin? I always thought penicillin was the gold standard for bacterial infections.
It's a totally logical thought, but it would completely fail here. Penicillin works by destroying the rigid cell walls of bacteria, but mycoplasma bacteria are incredibly unique. They literally lack a cell wall entirely.
No cell wall at all.
None. Firing penicillin at mycoplasma is basically like trying to shoot the tires out on a boat.
Huh. I love that analogy. So what do you use instead then?
You have to prescribe a macrolide antibiotic like chlorothromycin or azithromycin. Instead of attacking the non-existent cell wall, Macrolides go inside the bacteria and shut down its ribosomes.
So it stops it from producing protein.
Exactly. It neutralizes it from the inside out.
That is fascinating. It's all about knowing the exact mechanism of the enemy. Let's apply that detective work to a systemic autoimmune issue, multiple sclerosis, or MS.
Right, a really tough diagnosis.
Yeah, the source outlines a young woman of Northern European descent. She presents with transient blindness in one eye, optic neuritis, and maybe some muscle weakness that just seems to come and go.
Yeah, MS is the classic disease of lesions separated in time and space. Her immune system has essentially gone rogue and is actively attacking the myelin sheath.
Which is the insulation, right?
Exactly. The fatty insulation wrapped around the nerves in the central nervous system.
Yeah.
Without that insulation, the electrical signals just misfire or they stop completely.
And to definitively diagnose it, the book specifies needing an MRI using a high field magnet, like at least 1.5 Tesla. Why so specific on the actual machine specs?
Well, because the demyelinating lesions in the white matter of her brain and spinal cord can be incredibly small.
Oh, so a standard machine wouldn't see them.
Right. A lower resolution MRI might completely miss them, and that leaves you without a diagnosis while her nervous system just continues to degrade. You need the high field magnet for clarity.
That makes a lot of sense. Shifting gears to pediatric trauma now, we have to talk about the Salter-Harris classification for growth plate injuries in kids.
Oh, this is a vital one for primary care.
Specifically, the Salter V fracture. A kid comes in after a heavy impact, but the X-ray looks completely normal. Why is this specific fracture so notoriously hard to see, and why is it so incredibly dangerous?
It is terrifying because a Salter V is a pure compression or crush injury directly to the physis, the growth plate itself.
Okay.
The growth plate is made of actively dividing cartilage. Now, on a standard X-ray, bone shows up as bright white, but cartilage is radiolucent.
Meaning the X-rays pass right through it.
Exactly. It's essentially invisible on the film. It just looks like an empty black space between the actual bones.
So if it's crushed, you can't see the crack because there's no bone to crack.
Precisely. The invisible space is just violently compressed. Even though the X-ray looks totally benign, that crush injury destroys the cartilage cells.
Oh, no.
Yeah, it carries the absolute highest risk for premature growth arrest, which leads to permanent severe bone deformities as the child grows. You just can't rely on the X-ray. You have to suspect it based purely on the mechanism of the injury and the clinical tenderness.
That is exactly why you can't just treat the image. You have to treat the actual patient in front of you. Let's look at one more systemic connection. Neonatal rubella.
Right.
A pregnant teenager presents with what the text calls a morbilliform rash. Let's translate that. It basically means it looks like measles, red and blotchy. And she has Flower-Cymer spots on the roof of her mouth. The text specifically warns not to confuse these with Koplik spots.
Yes, very important distinction.
Yeah.
Koplik spots are tiny white lesions on the inside of the cheek, and they mean the patient actually has measles.
Okay, cheek equals measles.
Right. But Flower-Cymer spots are on the palate, the roof of the mouth, and along with that rash, they tell you she has rubella.
And if she's in her first trimester, the viral transmission to the fetus is just devastating. The book lists congenital cardiac anomalies, specifically something called a patent ductus arteriosus. In plain English, what is happening to the baby's heart?
So before a baby is born, they don't breathe air, right? So they don't need to send blood to their lungs.
Because mom is doing the breathing for them.
Exactly. The ductus arteriosus is a temporary blood vessel that allows blood to just bypass the fetal lungs entirely. Normally, within days of birth, that vessel closes off permanently.
But with rubella.
The rubella virus disrupts that fetal development. The word patent in medicine means open, so the vessel fails to close.
Oh, wow.
Which means the newborn's oxygenated and deoxygenated blood are just violently mixing, causing massive heart failure. Recognizing those spots in the mother's mouth is really the only way to trigger the necessary prenatal echocardiograms and interventions.
It is staggering to think about. I mean, imagine you were sitting in that clinic, you're 5 hours into your shift, and you have to seamlessly jump from analyzing eardrums to spinal cords to invisible cartilage to fetal cardiology.
It's mental gymnastics, honestly.
But of course, catching emergencies is really only half the battle. We have to talk about the long game. Preventive health and chronic management. The ultimate goal is, obviously, to keep the patient off the operating table in the first place.
And that requires really rigorous evidence-based screening. The text gives a highly practical example for this. A 45-year-old female patient comes in who hasn't seen a doctor in 6 years. You have to rebuild her preventative baseline from scratch.
Okay, so obviously a pap smear for cervical cancer, and the guidelines in this text recommend starting annual mammograms at age 40. But what about colorectal cancer or CRC screening for average risk that usually starts at age 50, right?
Usually, yes. But the vignette specifically notes she has a sister, a first-degree relative with a history of polyps.
Ah, so genetics change the math.
Completely. That family history alters the protocol. Because of that genetic risk, her CRC screening must begin at age 40. Plus, given this 6-year gap in her care, she absolutely needs a baseline complete blood count and a comprehensive chemical profile just to hunt for hidden metabolic or hematologic issues.
Speaking of metabolic issues, let's talk about the absolute epidemic of our time, diabetes and obesity.
Huge part of primary care.
The text presents a 45-year-old diabetic male who weighs 240 pounds. Now, the book gives a super specific dietary prescription. It says 1,200 calories, specifically broken down as 164 grams of carbohydrate, 45 grams of protein, and 45 grams of fat.
Very specific.
Yeah. But instead of just memorizing exact grams, what's the actual underlying philosophy here? Why is it so rigid and precise?
Well, the philosophy is metabolic balance and insulin control. It is absolutely not just about, quote-unquote, eating less to lose weight.
Right.
If he eats 1,200 calories of pure carbohydrates, his blood sugar will wildly spike, causing immense vascular damage. And then his body will pump out massive amounts of insulin, which actually promotes fat storage.
Which defeats the whole purpose.
Exactly. By rigidly balancing the macronutrients, you are stabilizing his glucose absorption over the entire course of the day. It allows his body to safely shed weight without throwing him into some dangerous hyper or hypoglycemic crisis.
And beyond the diet, the American Diabetes Association guidelines for monitoring are very clear about what you do and do not need to check.
Yes. For example, you do not need to order an annual EKG for an asymptomatic diabetic patient. It's honestly just a waste of resources.
But what do you check?
You absolutely must hunt for microvascular damage. High blood sugar acts like literal sandpaper on the tiniest blood vessels in the body.
That sounds awful.
It is. So they need an annual ophthalmologic exam to catch proliferative retinopathy before they go blind. They need an annual microalbumin urine test to catch protein leaking through damaged kidney filters. And they need quarterly glycohemoglobin or A1C checks to see what their average blood sugar has been over the last 3 months.
You know, relating this all back to you listeners out there, so much of modern medicine feels like simply managing these lifestyle changes and handing out chronic medications. But it's not just taking a pill. I want to push back on the pharmacology here because these quote-unquote miracle treatments have their own hidden dangers.
That is such a crucial point, and it's a trap that so many young clinicians fall into. Take smoking cessation, for example. Yeah. You might prescribe varenicline, which is known as Chantix. It's incredibly effective at blocking nicotine receptors. But if you don't warn the patient about the side effects, it will fail.
What kind of side effects?
Well, it can cause severe, just intolerable nausea or extremely vivid, bizarre, often terrifying dreams. If you don't counsel them beforehand, they will abruptly quit the medication and just go right back to smoking.
What about statins? The HMG-CoA reductase inhibitors we seem to hand out like candy to lower cholesterol. They are phenomenal for preventing heart attacks, but they carry a real risk of rhabdomyolysis. What is actually happening in the body when a patient gets rhabdo?
Rhabdomyolysis is the rapid breakdown of skeletal muscle tissue. The muscle cells basically die and release their contents, specifically a protein called myoglobin, straight into the bloodstream.
And I'm guessing myoglobin doesn't belong there?
No, it is highly toxic to the kidneys. It literally clogs up the microscopic renal tubules, causing acute kidney failure.
Wow. And the risk isn't the same for everyone, right?
Far from it. The risk is significantly exacerbated by advanced age, diabetes, and concurrent liver or kidney disease.
So you have to be careful who gets it.
Right. If you blindly give a high-dose statin to an elderly diabetic who already has mild kidney impairment and you don't aggressively monitor their muscle enzymes, you are setting a trap that could permanently destroy whatever remaining kidney function they have.
It is such a delicate, high-stakes balancing act. And that really brings us to the end of this incredible journey through the realities of the clinic. We want to thank you for joining this deep dive. From the ticking clock of a spinal epidural abscess to understanding why a vitamin deficiency basically paralyzes the eyes, Primary care truly is the ultimate intellectual puzzle.
It really is. And it raises a final thought that I want to leave you with today. We live in an era of hyper-specialization in medicine. We have brilliant doctors who spend their entire decades-long careers focusing on just a single organ, the heart, the kidney, the brain.
Yeah.
But considering everything we've discussed today, is the primary care physician actually the most complex specialist of all? They're the only ones tasked with acting as the sole conductor of the entire human physiological orchestra. They have to hear when a single tiny instrument is out of tune long before the whole symphony collapses.
The conductor of the physiological orchestra. I absolutely love that. Now, before you go, as promised for our dedicated learners out there, here is your review question to lock in what we've covered today.
Get ready.
Think back to our discussion on urgent triage. A 60-year-old diabetic patient presents to your clinic with unremitting lower back pain that is not relieved by sitting, standing, or lying down. He has a low-grade fever and an elevated white blood cell count with a shift toward immature forms. He has no urinary symptoms. What is the most critical next diagnostic step, and what life-threatening condition are you trying to rule out?
Take a second. Lock in your diagnosis.
The answer is you must order an urgent CT of the lumbosacral spine to rule out a spinal epidural abscess. If you got that right, you are well on your way to mastering the clinic. Keep studying, stay insanely curious, and remember that even when the diagnostic landscape seems completely murky, the clues are always there if you know exactly how to look for them.